There's a hidden risk at every doctor visit. We often shrug and say, that's aging. In reality, medical ageism can quietly change care and outcomes. Ageism means bias based on age. It can be open or subtle. A Yale team reviewed 422 studies and 7 million older adults. In 96% of those studies, ageism harmed health. The World Medical Association urged doctors to eliminate age bias in 2022. The World Health Organization calls it a global problem. I take this personally. After my dad's fall, someone waved off his dizziness with, "It's your age." That delay cost him weeks of struggle. You deserve better. This video is education, not medical advice. Do not change medications or treatments without your clinician. I'll keep language simple and steps clear. You're watching Age Strong, and I'm Drew Mercer. We'll cover 5 hard truths and the exact words to use in the room. We'll pair every truth with a practical response you can try today. Have you ever felt a doctor brushed off your concern as just old age? If so, you are not alone. Big groups like WHO and geriatric societies agree. It's time to name it and fix it. Let's start with number 1. In number 1, we have a common brush-off. You describe a new ache or fatigue. The answer you hear is, that's just your age. That sounds small, but it can hide real disease. Research interviews with older adults show a pattern. People report being ignored, rushed, or given little information. Some doctors skip testing when the patient is older. A senior with chest pressure may not get a full heart workup. A new depression is labeled normal aging instead of screened. That delay risks worse outcomes. Reviews in geriatric medicine warn that mislabeling symptoms as aging is dangerous. It weakens trust and causes late diagnoses. Here is the key idea. New symptoms are not normal until proven otherwise. Aging changes systems. Still, shortness of breath, sudden weakness, new confusion, weight loss, and steady fatigue deserve a full look. Quick tip for your next visit. Write 1 page before you go. List each symptom when it started and how it limits life. Say, I want this checked. Bring your list into the room and hand it over. That keeps the focus on your concern. If age gets blamed, you need a plan to be heard. That plan is next in our response to number 1. Response to number 1 starts before the visit. Prepare a clear note. 1 page only. Use bold, simple lines. Symptom, start date, frequency. What makes it better or worse? Impact on life, like stairs, sleep, or meals. At the top, write your goal for the visit. For example, rule out heart or thyroid problems. In the room, use specific language. Instead of, I'm tired, say I feel exhausted every day by noon. Instead of, it hurts, say burning knee pain. 7 out of 10 stops my walks. Then add a direct request. Say, could this more than aging? What else should we test? Ask the doctor to explain their thinking in plain words. If you feel rushed, pause. Gently say, I have 2 more items on my list. Bring a trusted person if you can. Another set of ears helps. Some patients record notes on paper or phone. Clinics and groups like the National Institute on Aging encourage this kind of preparation. If you still feel unheard, ask for a second opinion. A fresh set of eyes can make a big difference. With your voice steady and clear, we move to number 2, the medication pileup. In number 2, we face polypharmacy. Polypharmacy means taking 5 or more daily medicines. At each checkup, pills get added. More is not always better. About half of adults over 75 take 5 or more prescriptions. Around 1 in 5 prescriptions for seniors may be inappropriate. That means the risk could be higher than the benefit. Global groups like the WHO and OECD have flagged this for years. Some risky drugs, like long-acting benzodiazepines and certain antipsychotics, still show up in older patients. Too many meds raise fall risk. They can cause dizziness, confusion, constipation, and hospital stays. Sometimes a new pill treats a side effect from an old pill. That creates a cascade. Age bias can creep in here. Pills can be faster than looking deeper, but the safer path is thoughtful review. Ask yourself, does each drug still match a clear goal? Are doses right for kidneys and liver today? Are there non-drug options to try first? Medication safety is a core part of good aging. It is not about blaming anyone. It is about a safer routine. Your next step is a calm, structured review. I'll show you how to do that in our response to number 2. Response to number 2 is simple and powerful. Do a yearly medication review. Sooner if you feel off. Step 1, gather everything you take. Prescriptions, over-the-counter, pills, vitamins, drops, creams, powders, herbal blends. Put them on one list with dose and time of day. Step 2. Book time with your doctor or pharmacist. Bring the list and your concerns. Go item by item. Ask, what is this for? Do I still need it? Is my dose right for my age and kidneys? Could we lower it? Could we stop it safely? That is called a Deprescribing plan. Reviews like these have cut inappropriate meds by meaningful amounts in studies. Many Medicare plans cover pharmacist consults. Use a pill organizer and a simple schedule. Watch for side effects like dizziness, constipation, or sleep changes. Report new symptoms quickly. And please hear this, do not stop a medication on your own. Stopping suddenly can be dangerous. Partner with your clinician at every step. With your meds cleaned up and safer, another problem often remains. Many older adults still live with daily aches. That brings us to number 3, pain that gets downplayed. In number 3, we face a stubborn myth. Chronic aches are not just aging. Yet many people are told to rest and endure it. Studies show older adults often receive less pain assessment and less treatment than younger patients with the same reports. Some reviews even call undertreated pain in elders a neglect issue. The result is lost sleep, low mood, and less movement. Pain limits walking and balance. That raises fall risk. Many seniors also downplay pain to avoid being a burden. I hear it in clinics all the time. I had a client who stopped gardening because of back pain. She was told, that's age. After a proper exam and a few weeks of guided therapy, she was back outside smiling. The International Association for the Study of Pain says adequate pain relief is a human right. Geriatric medicine agrees. We should treat pain based on the person, not the birth year. Here is the quick win. Use precise words and numbers. Say burning, stabbing, or throbbing. Rate your pain on a 0 to 10 scale. Say how it blocks your life. Your clear report opens doors. Next, I will give you the steps to get the relief you deserve. Response to number 3 is all about clarity. Keep a 1-week pain diary. Note time of day, what you were doing, pain level from 0 to 10, and what helped. Bring that page to your visit. Lead with function. Say, knee pain makes me fear falling, or back pain keeps me up 3 nights a week. Ask for a focused exam and a plan. Discuss options, physical therapy, gentle strength work, heat, or ice, topical creams, and safe medications. Ask what is safe with your other conditions. If pain is severe or new, ask if imaging or a specialist is needed. If memory or hearing is a challenge, bring a family member to speak to patterns they see. Be honest about worries. Say, I'm afraid a fracture is hiding. Many clinicians change course when they hear clear, concrete stories. If this helps, please subscribe, like, and share. It supports more evidence-based guides like this. Save this video to try later. With pain on the table, there is one more area that often gets quietly ignored: mood and memory. That brings us to number 4, when depression is brushed off as normal aging. In number 4, we face mental health bias. Feeling sad, anxious, or foggy is not just old age. Large reviews led by Yale researchers link ageism to worse depression in older adults. Many seniors get fewer referrals for counseling or psychiatry than younger people with the same symptoms. In some surveys, only a fraction of older adults with clinical depression receive care. That gap harms health. Mood affects sleep, appetite, pain, and recovery after illness or surgery. Bias shows up in small ways. A doctor may say, of course you feel down at your age, or therapy will not help at 90. Those ideas are wrong. Older adults can benefit from talk therapy, social connection, and when needed, medication. Clinics now use brief screens that take minutes. Treating depression can lift daily function and even improve heart outcomes. Grief is real. Loneliness is real. But suffering in silence is not required. Your feelings deserve the same attention as your blood pressure. Name the concern clearly and expect a professional response. Next, I will show you the exact words to start that conversation and the steps to get support. Response to number 4 starts with naming it. Say, I feel very down, or I feel anxious most days. Add how long and how it affects life. Sleep, appetite, energy, interest. Ask for a screening today. Many clinics use a simple tool called PHQ-9. It helps measure depression symptoms. Then ask about options, counseling, group support, or a referral to a geriatric psychiatrist. Many clinics now offer phone or video therapy. Ask if that is available. If you prefer medication, ask about the expected benefits and side effects at your age. If memory worry is present, request a brief cognitive screen too. Bring someone you trust. A spouse, adult, child, or friend can share what they notice. This is not shame. This is healthcare. Studies show that when we address mood, pain treatment works better and recovery improves. If your concern is brushed off, ask for a follow-up specifically for mood or seek a second opinion. You deserve care at any age. With symptoms, meds, pain, and mood addressed, it is time for number 5. This one can be life-changing. Sometimes aggressive treatments are held back from older adults. In number 5, we face a hard truth. Older adults sometimes receive less aggressive care than younger patients with the same condition. Look at heart disease. 30 to 40% of hospital heart attack patients are over 75. Yet as age rises, rates of procedures like angioplasty and bypass often drop. This happens even when a patient is otherwise fit. One reason is poor evidence. Many clinical trials excluded older adults for years. Doctors are left guessing. Some choose conservative care by default. We see similar trends in cancer surgery and joint replacement. A fit 80-year-old may be told to wait and see, despite strong potential benefit. Professional groups push back. The American Geriatric Society and Heart Society say age alone should never decide treatment. We should use functional status and goals of care instead. Laws and policies in the United States also forbid denying care based only on age. The message is simple. You deserve full consideration. Your options should be explained clearly and fully. If you sense your choices are shrinking because of age, you can respond. I will show you how in our response to number 5. Response to number 5 is about respectful pushback. Start with curiosity, not conflict. Say, help me understand why I am not a candidate. Ask for specifics on risks and benefits for someone like you. Ask what the evidence shows for people your age and health. Request to review all options, including surgery, procedures, or advanced therapies. Ask what recovery looks like with each choice. If you hear only age as a reason, pause. Say age alone should not decide care. Could we look at guidelines or get a specialist involved? Consider a second opinion from a geriatric cardiologist, oncologist, or surgeon. Bring a family member or caregiver as your advocate. Many hospitals have patient advocates and ethics teams. Use them if you feel dismissed. Regulations from Medicare and other agencies state that age cannot be the sole criterion for care decisions. Write your top 3 questions on one card and bring it in. Keep the conversation calm and steady. You're asking for informed choice, not special treatment. With these tools, you can turn a no into a thoughtful discussion. Now let's pull it all together with a quick recap and one clear next step. We just covered 5 hard truths and 5 responses. Here is the quick recap. 1. Do not let new symptoms be labeled as just age. Bring a clear list and ask for a workup. 2. Review every medication once a year, pause before adding more, and deprescribe safely with your clinician. 3. Describe pain with numbers and impact. Push for a plan and support. 4. Treat mood like any other symptom. Ask for screening and real options. 5. If care is held back, advocate for full choices and get a second opinion. Positive attitudes and clear requests do help. Reviews link lower ageism and better mental health. Your next step is simple. Download the checklist linked below. Print it. Put it with your insurance card. The first line reads, "List my top 3 concerns." This channel is for education, not medical advice. Always consult your healthcare provider before any changes. What will you do differently at your next doctor's visit? Please subscribe for more clear evidence-based guidance and share this with a friend. Thanks for watching, and thanks for helping build a kinder system. Together we keep each other strong and safe. Thanks for watching Age Strong.